Hey guys, how are you doing today? So basically, it is we are basically just continue what we did in the first topic. So it is the same chest pain patient, the same 1 hour. If you will see the same cardiac enzymes high, if you remember, and ST elevation, and this ST elevation again, these are wall leads, and you will see basically as we were discussing in the first video, we were talking about cardiovascular system. And the answer was endocardium or myocardium. We choose myocardium because it's myocardium necrosis. Now look at the second one. Now the second one basically is subcategories within the system itself. So you know already that he is talking about cardiovascular system, but in this case, which part of the cardiovascular that he's talking? If you remember, we divided into coronary artery disease category, or congestive heart failure, or cardio myopathy category, congenital heart disease, valvular heart disease, and pericardial disease. This is usually what we did, plus the infectious types. Now you will see the options are really interesting. After the options, you will see the explanations. And basically the reason for this video, how to rewrite these explanations in different way. Guys, you cannot rely on these explanations and rewrite it in your notebook like this, because it's very hard for you to recall them. So what you need to know, you need first to read it, and then you will try to write down any things that either you are weak in or unfamiliar, right? This is usually the approach. So this is basically the second questions type, which I feel is maybe more important than the first one. The first one is a kind of easy. I mean, organ type is really easy if you will get it. Sometimes it's confused, sometimes, but most of the I feel it's fine. Now again, this is with the cardiovascular system. So basically, look at the answers. The answers, first he's talking about the viral, and when he's talking about the viral, I think the only problem with the viral heart disease, you could say either viral pericarditis or viral myocarditis. Although maybe it's not really specific, but here in the question I was talking about viral myocarditis, which is the most common, which is basically I'm not sure the most common, but one of the common cause of myocarditis is basically viral myocarditis, right? Which is Coxsackie A virus. Now, the issue here, it is chest pain, the same chest pain acute, so it's the same. While there is history of upper respiratory tract histories of upper respiratory tract symptoms, plus there is muscle enzymes. So the enzymes here are increased, right? So the enzymes are increased. So how you will rewrite these? You will just say the same acute chest pain patient. So it is acute chest pain patient plus upper respiratory tract infections, plus which is usually fever, and this fever usually low-grade fever, plus enzymes. So that's it. And instead of these 3-4 lines, you will just try to make it by just few words: upper respiratory tract fever, enzymes, Coxsackie A virus. This usually myocarditis. All right. So that's it. Now look at the second one. The second one, basically, look at the options. You will see the options is necrosis. And when you are talking about necrosis, guys, I'm talking about the MI. And now, excuse me, I told you allergy. And when you're talking about the MI, you have to know if there is ST elevation or ST depressions. Usually ST elevations, MI, which basically Q wave are present, so that's why positive. ST depressions, the Q wave may be negative. And ST elevations also it means transmural. I mean the whole wall is involved, so transmural. While ST depression means subendocardial. Now be careful, this is not ischemia. For both of them, you are dealing with necrosis pathology. So for both of them, if you remember when I draw the slide, when I draw the vessels in the first slide, so for both of them, this is the vessel wall and this is disrupted blocks. So the block disrupted and basically closed the whole vessels. That's why you have here obstruction. Right, you have here obstructions. This is really very high yield. Although usually I believe for ST elevation is the most common. I'm not sure, this is maybe, I think they still use it in pathology, but usually really in clinical medicine, ST elevation, Q wave positive, this usually indicates transmural, and that's basically necrosis. So guys, this is the approach how you will study. Look at that again. It's just you need to keep into your mind some key point. So first, ST elevation. Oh, that's really crazy. I don't like it. Give me one second. Why is that? So first, ST elevation is the same as Q wave, guys. Is the same as transmural. Is the same as basically necrosis, and this necrosis total obstructions. Or maybe if this is the same, you can say ST elevation is the same as Q wave, the same as transmural, which is part of the MI. Now, whenever you hear ST depression, Q wave absence, and this is subendocardial. So again, there is no way to confuse between those two, because it's really clearly cut between them, right? So maybe he will not tell you it's necrosis a problem. So he will tell you maybe it's necrosis part of the wall. That means he indicates subendocardial. So in this case, ST depressions, right? Or maybe the whole wall necrosis. So basically, he's trying to refer that he's talking about ST elevation MI. So now when you will see the explanations, look at the explanations. I hope it's clear, but look at the explanation. The explanation, look at how it's difficult. The symptoms are consistent with transmural myocardial infarction with EKG finding with increased cardiac enzymes. So this cardiac enzyme is increased myocardial transmural, which is basically cardiac enzymes, and it is also the same as the whole wall. Called transmural, in this case Q wave and ST elevations, and the opposite while, and he was talking about the opposite side, cardiac enzyme, and he's talking about the subendocardial one, Q wave. Both of these cases, cardiac enzyme and CK elevated. Yeah, by the way, both of those, whether it is, this is another approach, both of those, whether it is transmural, subendocardial, usually CK, which is creatine kinase, troponin usually elevated. So always any necrosis, you have elevated CK and you have elevated troponin. So this is how you will make the second paragraph, because really the second paragraph, again, when you go and read it carefully, you will see it's a kind of written in a complicated way. Although usually my language is simple, but I mean when he's trying to explain everything in the questions, usually you get lost. So there is no way to make it unless you have to convert it into diagrams. Really. Now, for ischemia, when he's talking about ischemia, that's when he's talking about angina. And here, guys, basically you have to know angina usually ST depression. But if you will see, after angina, you go with enzymes, right? You go with enzymes. If you will see the enzymes positive, that's been here, maybe you are talking about unstable angina, right? Unstable angina enzymes also could be positive, although it's not necrosis, but it could be positive. If it is negative, that means maybe it's talking about early unstable or maybe just a stable angina. So this is also another interesting approach for angina. You will see it's the same here. Basically, look at what he's saying. Angina could be classified into stable angina, which is due to atherosclerosis. Stable one means a stable plaque formation. Look at the pathology. Pathology is just a stable plaque. Means the obstruction usually more than 70%, but it's not totally obstructed, and it is subendocardial. Those patient chest pain during exercise. So for a stable one, you can say exercise is a key point. You can say 70%. You can say ischemia, right? And then subendocardial. And the cause of stable plaque, right? Now look at for unstable. You'll try to read it. Oh, plus sure ST depression. Now ST depression, no cardiac enzymes. Yeah, sure, there is no cardiac enzyme. While unstable angina, which is basically here, disrupted plaque formation. So you will see instead of stables, you can say unstable plaque, which is basically disrupted the plaque formations, right? Now ST depression, stay ST depressions. Thrombi, yeah, I said this. Frequent chest pain without that exercise, ST depression the same. You know, it's usually no cardiac enzymes, but I think in a clinical medicine usually cardiac enzyme is present. But I think this is pathological wise, I'm not sure. But high risk for progression to acute MI. Now, how you'll make it? You will say first, instead of exercise, you will make it by rest. maybe, or frequent chest pain, right? Stay ischemia is pathology. And around the wall, I think it's subendocardial to transmural. I'm not sure about the wall, so I don't think he will ask you about the wall here. I don't think the wall is really an issue for unstable. So this is this unstable one. So unstable one, basically it's rest, frequent chest pain, unstable exercise, chest pain and exercise. This is ischemia, this is ischemia, this is ST depression. ST depression, the only different in the plaque formations. Now, for immune myocarditis, he's talking about the group A streptococcal infections, and the cause of injury is not due to the group A streptococcal cells, but basically group A streptococcal will liberate antibodies, and these antibodies will go and attack the myocardium. Right? This is pathology. That's why they call it immune, because it's not due to the infection. The infection will enhance immune response, and immune response will attack myocardium, endocardium. If attacking endocardium, you will have basically valvular problems, because endocardium is valve problem. Myocardium also you will get a kind of carditis or myocarditis or carditis. Now here the big issue is you will see systemic features, which is very interesting. Very interesting. So he has to tell you something about systemic features, like arthritis, subcutaneous nodules, chorea, erythema marginatum. So he has to give you something. So I think this is really specific, not specific, it's unique in compared to other coronary artery disease. So it's really not coronary artery disease. Now for Prinzmetal, which is really interesting, here guys, this is the only time, maybe he's the only time that past medical history will be different. I don't think he will say something about diabetes or hypertensive here. I don't think even the case will be older age, like 66. So what do you think the past medical history for this patient? Any idea? Just try to think. Because it's a spasm pathology, so maybe he will give you another spasms problems in the body. Another spasm problem in the body, maybe he will give you the patient have history of migraine, right? Or maybe the patient have history of Raynaud's. Or the patient maybe have achalasia. All of these are kind of spasm pathology. Now, if you remember our approach, age usually it's young age. Alright? So you get young age different. You get risk factor different. How about chest pain? Chest pain looks like MI. So you can say chest at rest. Enzymes positive, guys. ST elevation. It actually looks like MI. But it's usually short spasm. The spasm is really short, within a few seconds, but it's really severe pain. So look at that, guys. This is almost the same as MI. Alright? Same as MI. But you can say short spasm. So the pathology here is a spasm, guys. Right? The pathology is a spasm pathology. And yeah, by the way, famous questions about that, which is calcium channel blockers is the treatment of choice, right? Calcium channel blockers. So you get a spasm as pathology here, basically Prinzmetal angina. You get immune problem, which is basically rheumatic fever or rheumatic heart disease. And you get, what else you get? You get ischemia or necrosis. And ischemia, we were talking about unstable angina. This is ischemia here, right? And this is necrosis. Now you think that you made it, but I made it here a lot of scratches. So this is what you did, what you will do by the end of the question. Sure, you will not do this. I just doing that. I just did a lot of details just to show you how to approach it. But what you get at least here, you get chest pain questions, and you get chest pain. You assume this is cardiac because. Or let's say you got positional so far in my questions, right? Which is basically we divided into, if you remember, we divided into GI problems, which is achalasia, right, or GERD, or we divided into pericarditis, right, and pleuritis, pneumonia. You remember these 5 or whatever, pneumothorax. And each one of them has different features. So I will not go over this positional because really we went over this in the first time. Now, second things, you get the cardiac. Now the cardiac, look at the vessels, how you will make it. You get the first vessel usually looks like this, 70%. And then you get the vessels down now disrupted, but still there is a flow. And then the vessels totally disrupted. So I will make the second vessel still there is a flow. Right. So here basically 70%. Here you can say disrupted, positive, negative thrombi. And here you can say occluded. So the first one is at exercise, the chest pain. The second one usually at rest, and the last one is at rest. And this you can say increase frequency, right? Increase frequency. Now the surface usually here you can say subendocardial. Here both subendocardial, epicardia. Honestly, maybe it's just the same as subendocardial and stable angina, but here both, which is either transmural or okay. Let me make transmural and subendocardial later. Let me make the surface later because we need to go with the EKG findings. So for both of them, this is ischemia pathology, right? For the last one is MI, which is necrosis pathology. So you get MI here, you get unstable, and you get stable. Right. This is basically what the questions and what the explanation said. Now, after that, you will go with ST, which is bigger problems. ST changes. Nobody like it. This is usually ST depression for both of them. Now for MI, if it is subendocardial necrosis, you will go also with ST depression, right? This is how you'll make it. Now look at the MI. The MI in general is ST elevation. So, and the main differential diagnosis is basically transmittal angina. So you can make it this way, or you can make it another way. So basically for ST depression, guys, you get three causes. You got stable, you got unstable, and you get subendocardial necrosis. For ST elevation, you get two. You get the transmural, so you can say here it's transmural MI, right? Differential diagnosis transmittal. What is the difference? This is usually spasm. While for all of these, by the way, for all of these, what is the main pathology for all of those, whether it's stable, unstable, or MI? The main pathology for all of those. Although I talked about ischemia and necrosis, but the main essential pathology is atherosclerosis. So for all of those is atherosclerosis. And you are talking about atherosclerosis, usually you will assume it's older, and right, and usually assume risk factors. And when I'm talking about risk factors, we mean hypertension, diabetes, smoking, right? Or there might be others. When you're talking about spasm pathology, usually we say it's basically young, and another spasm problems like the patient have achalasia, like the patient have Raynaud's, right? Or the patient have migraine. So this is different. This is the way that you make your book. And this is the way that you have to study. First, don't study tables or convert any tables in any book, in any QBanks, in whatever. Any tables has to be converted into diagrams. Any tables. Tables are wrong. Tables, I believe, tables are really the worst way of presenting materials. And maybe you can make it a different way. ST, right, which is easier. Now, ST depression, you have three differential. 1, 2, 3. ST elevation plus enzymes, right? You get 2. If it is short duration, so basically here you are talking about spasm. Or maybe long duration, you are talking about MI, right? So you get these. Now, look at, we can make it more complicated. ST depression we can go with the second step, enzymes, to see if the enzymes. Now, if the enzyme is negative, so your answer has to be stable, usually stable. Now, unstable sometimes also, but it's stable. Now, enzyme is positive, in this case, you will go with unstable. Right? How about, am I subendocardial? You can also make it here. But I don't think you will see this last questions. It's hard to make questions about subendocardial am I. It's really hard. So this is this one, that transmural, which is basically Q wave. This is the one that's important. Right? This is the only time that you treat the patient by calcium channel blockers. Not the only time, but I mean, really interesting here, calcium channel blockers. So this is how you made the explanations. Now, beside that, maybe, yeah, this is basically how you did the explanations, the questions. Maybe you can, although this is usually for the ST, maybe you can add another chest pain. Another chest pain in your questions was viral. You get the case of viral, which is chest pain, and patient have history of upper respiratory tract infections, and enzymes positive. So that's it. And finally, the immune. The immune, basically, I think we'll talk about rheumatic fever later, because immune is really, or maybe you can say, wait a minute. Maybe just one word for immune. What is that? Clinical case, one word. It's just systemic features, which was really unique. I mean, when I talk about systemic feature, which is arthritis, myocarditis, right? Erythema marginatum, chorea. So this is really interesting. So this is guys who will make the questions. If you are not paying attention to the keywords, if you are not making notes like this, you will not be able really to pass the exams. Materials are great, but the materials, multiple materials written in a classical way, you have to go over 5 or 10 diseases at the same page. And if you see my question, which is very easy, we went over non-cardiac chest pain in the beginning. Although this is the non-cardiac chest pain, it's just one question. We went over maybe GI pericardial, right? It was here GI, here was pericardial, and here was pleurisy. We went over these quickly, and pneumonia. But the cardiac one, I think we discussed it in really thorough. So basically, we discussed the coronary artery disease, and we talk about coronary artery disease, two major problems, whether it's atherosclerosis is a problem, and we divide into 3 types, which is MI, angina, or stable, unstable, and finally we went over spasm, and we went over some differential diagnosis, which is myocarditis plus rheumatic fever. Right, sorry, I know the handwriting is crazy. So this is how you make. So if you will count how many diseases that you went over, maybe for cardiac, maybe for non-cardiac, I can tell pericarditis, GI, this is 1, this is 2 differential. And for coronary artery disease, you went over 3 MI, you went over 2 types of stable, unstable angina. At least you know the clinical features, and at least you know the clinical for myocarditis, and 1 unique thing for rheumatic fever. So you got 7. You get 7, and which is basically your options. Your option will see 5, sometimes you'll see 7 options. It will not be detailed, but usually key point and major principle of pathology, major principle of complications, and guys, in this case, really, you will be fine. So hopefully this is helpful, and I hope I can continue with this series. I'm really excited to make this series, maybe just in cardiovascular pathology and physio. This is basically my target. And again, just feel free, subscribe, comment, like my videos, or even dislike, whatever you will, whatever you feel it's okay. I will be more than happy. If there is any mistake, you can just correct me. And I would be more than happy to help. All right, so sound good, and have a good night.